Respiration includes four processes: pulmonary ventilation, that is the movement of air into and out of the lungs; external respiration, that's the diffusion of oxygen from the air into the blood and carbon dioxide from the blood into the air; then the transport of respiratory gases, including moving both oxygen and carbon dioxide through the blood; and then when that blood gets to some other body tissue, we have the process of internal respiration, the diffusion of oxygen out of the blood and into that body tissue, and the diffusion of the carbon dioxide that tissue has been making from the tissue into the blood. In this discussion, we're going to focus on pulmonary ventilation. Pulmonary ventilation relies on pressure gradients. Just like fluids, like blood and lymph, move down their pressure gradients, so do gases like air, oxygen, and carbon dioxide. We move gases into and out of our lungs, the process of pulmonary ventilation, by changing certain pressures. The most important pressures we need to know for this process are atmospheric pressure, the pressure of the air around your body. At sea level, this is about 760 millimeters of mercury. And we also need to know this intrapulmonary pressure. Intra tells us within, pulmonary means lungs. Intrapulmonary pressure is the pressure of the air within the alveoli of the lungs. If this intrapulmonary pressure is lower than atmospheric pressure, that gas moves down its pressure gradient from the atmosphere and into the lungs. If intrapulmonary pressure is higher than atmospheric pressure, then gas is going to move down its pressure gradient again. This time, though, it's going to move from the lungs out of the body. You may also recall from our discussions in human anatomy that the lungs are surrounded by a couple of different membranes called pleura. There's a visceral pleura that sits directly against the surface of the lung itself, and a parietal pleura that sits more out against the body wall, like against the muscles and the bones. Between these two membranes, there's a small space or gap called the pleural cavity. This pleural cavity also has its own pressure that's called the intrapleural pressure. And this pressure should always be negative, meaning it should always be lower than the intrapulmonary pressure. This is important because this negative, low pressure out on the surface of our lungs helps pull out on the surface of our lungs and prevents them from collapsing all the way down. If intrapulmonary pressure ever rised, then that pressure would start to push against the surface of the lungs and cause the lungs to collapse. Pulmonary ventilation is a mechanical process. That means we use muscles to change volume inside of the thoracic cavity. And this change in volume causes a change in the pressure in the intrapulmonary and the intrapleural spaces. That changing pressure causes changes in pressure gradients, adjusting how intrapulmonary pressure is related to atmospheric pressure. That change in pressure gradient changes the direction of airflow, whether it's coming into or out of the lungs. In inspiration, we have a couple of skeletal muscles that are going to play an important role, including the diaphragm and the external intercostals. The diaphragm is a muscle that separates the thoracic cavity from the abdominopelvic cavity, and in its relaxed form, it kind of forms this mounding dome type of shape. During inspiration, when we're trying to take air into the lungs, the diaphragm actively contracts and starts to push its way down. As this mound starts to straighten out, it means that there's more space available in the thoracic cavity. Because the air that's in there doesn't really change volume right away, we have the same amount of air trying to fill a larger area. That means that pressure starts to decrease quite rapidly. At the same time this diaphragm is contracting down, our external intercostals do contract up and grab the rib cage and pull it up and out, further increasing space in the thoracic cavity, further decreasing pressure. Once pressure in the thoracic cavity, and especially in the intrapulmonary space, is lower than atmospheric pressure, air rushes in to fill that extra space. Normally, inspiration is an active process that causes small changes in this overall volume. However, we can actively increase inspiration by forcefully contracting the diaphragm down and exerting extra effort to contract the external intercostals up. This extra contraction creates even more room, which reduces pressure even further and causes an even bigger breath to move in. Expiration, on the other hand, is normally a passive process. We're relying on the diaphragm and the external intercostals relaxing and moving back to the resting state. As the diaphragm relaxes, it mounds up, pushes against the thoracic cavity, and increases pressure to push that air out of the lungs and out of the body. We're also relying on the elasticity of the lung tissue itself. As it expanded out, lung tissue has this elastic recoil effect that causes it to press back in against itself, increase pressure, and push air out of the lungs. However, we can force an extra large expiration by actively contracting a set of muscles, especially our abdominal muscles and our internal intercostals. By contracting our abdominal muscles, we also push up against the floor of this diaphragm and force it further into the thoracic cavity. And our internal intercostals contract to pull the rib cage down and in. This movement up from the diaphragm and down and in from the rib cage reduces the space in our thoracic cavity, greatly increases pressure, and forces a larger breath out when we're trying to do something like blow out a candle or blow up a balloon. In addition to pressures that must be overcome, ventilation can also be affected by resistance in the airways. Resistance primarily comes from decreasing passageway diameter or obstructions, kind of like we saw with resistance in fluid flow through the cardiovascular system. This kind of resistance in the respiratory system can be observed in an acute asthma attack, where the contractions of smooth muscles around the bronchioles force those bronchioles to constrict and reduce the amount of room that air can travel through. Alveolar surface tension is also another contributing factor. Water in the alveoli sticks tightly together and makes it difficult to expand the lungs. It would take a lot of energy just to force our lungs to expand, fighting against this surface tension. The effective surface tension is normally reduced by the production of surfactant within the alveoli. However, premature babies don't produce adequate amounts of surfactant and can have a difficult time just inflating their lungs. So it's common for premature babies to need assistance in getting this airflow into their lungs. A third contributing factor for ventilation is lung compliance, the ability of lung tissue to stretch. Normally, lung compliance is usually quite high, but it can be reduced by things like tuberculosis, causing an increase in non-elastic scar tissue on the surface of the lungs, or reduced production of surfactant. Because that surfactant would increase surface tension, it would also make the lungs less likely to stretch.